Dear students, welcome to NEET or Next, Day 6. The questions that we had displayed were the first one for the day. A 48-year-old obese hypertensive male developed severe chest pain radiating to the epigastrium. He was admitted in the intensive care and a complete panel of investigation done. Which of the following would clinch the diagnosis? Serum bilirubin 1.1 milligrams per cent, blood urea 24 milligrams per cent, serum alkaline phosphatase 38 units per liter, troponin I 1 nanogram per ml. Sometimes we give a deviating history. This is not deviating. Many an eminent cardiologist has treated himself with antacids to be found dead the next morning. That is why a radiation to the epigastrium is also possible. And the answer in this case is troponin I. The normal value is 0 to 0.4. The rest of the things I would like you people to kindly refer. There were a lot of such enzymes, lactate dehydrogenase, creatinine phosphokinase, etc. And troponin has been a remarkable game changer in this case. You find that a peak is attained within 12 to 18 hours. So this is useful in making a diagnosis. Courtesy Labpedia, and these are the sources of references. The diagnostic criteria for acute myocardial infarction is as given below. You people can go to your references in medicine for further information. I am interested in troponin T or I, creatinine kinase MB. Other things such as the ECG changes, elevation of the ST segment, etc. You people can read up in medicine. And the history continues. The patient succumbed to death within 12 hours of round-the-clock treatment. A post-mortem was done. This particular test was useful in confirming the cause of death. Triphenyl tetrazolium chloride, coagulative necrosis, left ventricle, cardiac tamponade, left ventricular aneurysm. All these are supposed to be autopsy findings. And the answer is triphenyl tetrazolium chloride test. What is this? In this particular picture, I am finding a massive left ventricular hypertrophy. The lumen is compressed, the walls are thickened almost uniformly in all sides. So this is called a concentric hypertrophy. In this case, there is a pale area. Probably this is an area of infarct. Now what happens is, to the cut slice of the myocardium, triphenyl tetrazolium chloride is applied. And this area doesn't take it up, whereas the rest of the viable myocardium takes up a red color. This is important in making a diagnosis because the key here is within 12 hours. Normally it takes 24 to 48 hours for the necrotic manifestations to be seen pathologically. That is why when there is going to be a sudden cardiac death, there will not be any changes seen at autopsy. So this you people should remember. Triphenyl tetrazolium chloride, when there is going to be a sudden cardiac death, maybe due to myocardial infarction, this is useful in making a diagnosis. The next question. A double barrel appearance is a term in pathology used to denote a dissecting aneurysm, intersusception, volvulus, atherosclerosis with perforation. And the answer is dissecting aneurysm. So look at this picture. It is a picture of and aorta. So this is the intima, the media, and the external red one is the adventitia. Normally, you find that the blood passes through it with a shearing force, which is increased in cases of hypertension. Also, in any case of hyperdynamic circulation, you find that there will be a shearing force. In disorders such as Marfan syndrome, you find that there is a weakness within the media, cystic medial necrosis. Therefore, there is a tear in the intima, there is a weak support in the media, and the blood tends to dissect through it, creating a second lumen. That is why you get a double-barreled appearance. So this might be a false lumen. Sometimes it can reconnect with the original lumen, creating a double-barreled aorta appearance. Look at this one. This is a true lumen, whereas in this case there has been a dissection outside and a second lumen also appears on cross section, mimicking a double barrel gun. Now students, please concentrate. There are two pictures on the screen. Let us go to the gross picture first. This is the ascending aorta, the arch of the aorta, and the descending aorta. This is what we are seeing in all the three pictures. There is a particular classification called as Debye's classification or a Stanford's classification. In the first picture, I find that the ascending and the arch of the aorta are involved as well as the descending aorta. This is one condition. Whereas here, the arch of the aorta and the descending aorta are involved, whereas the ascending aorta is unaffected. And in the third picture, I find that only the descending aorta is affected. The ascending is unaffected. This particular method of classification is for a nomenclature. And here I find that the aortic wall has been split and a false lumen has been created. It can be filled with blood or air. And you people can get questions from Debye or Stanford's method of classification also. The next question. An 18-year-old boy reported to the medicine OP with a history of low-grade fever. A complete hemogram was asked for. The pathologist gave a diagnosis of an acute leukemia because the leukocyte count was increased 98,000 per cubic millimeter. The blast count was increased 32%. Leukocyte showed a marked shift to left and the presence of neutrophilic toxic granulation. Which of these is the answer? The answer is blast count of 32%. The peripheral blood, when it shows a blast count of more than 20% and the bone marrow more than 30%, is diagnostic of leukemia. The blast percentage is important. And this is a classical picture of a blast. In this case, it is a myeloblast. I find it has got a large nucleus, prominent nucleoli, and the cytoplasm has got the R.A.T.S. So this is a classical picture. If it is going to be a lymphoblast, you find R.A.T.S will not be there, and there are other differences. Sometimes it will be difficult to make a diagnosis. But all said and done, a blast count of more than 20% is diagnostic of an acute leukemia. The next question. A 36-year-old alcoholic with irregular dietary habit was brought to the casualty in a semi-conscious state. On examination, the surgeon found a board-like rigidity in the patient. An X-ray was taken at the OP which showed this picture. There is an arrow mark also. So, what is our diagnosis? Is it a perforated peptic ulcer, a Hirschsprung's megacolon, blunt injury after endoscopy, or Chilaiditi syndrome? Which of these is it? The answer is perforated peptic ulcer. My professor Dr. Sarat Chandra used to say, in a case of perforated peptic ulcer, the patient develops a board-like rigidity. You can stand and dance on it. Chilaiditi syndrome is what I would like to explain in this case. Sometimes, because of a number of causes, you find loops of intestine can be caught between the liver and the diaphragm, as a result of which we get air pockets over here, which can be mistaken for a perforated ulcer. Of course, I am able to see some oscillations over here. So it can be hepatic in a case of cirrhosis, or it can be intestinal because of colonic motility, or sometimes it can be because of pregnancy, aerophagia, etc. So this particular syndrome, which mimics a perforated peptic ulcer, is called Achilles syndrome, which I would like you people to kindly refer. And this is what we see in this case. I find that there is a definite shadow and there is a even plane over here, showing an accumulation of a fluid. Fluid means air is also a fluid. And this can be seen in a number of conditions such as a perforated peptic ulcer, endoscopic procedures, typhoid trauma, ruptured ventriculum, diverticulum, necrotizing enterocolitis, colonic cancer, peritoneal dialysis, and sometimes there can be entry of air via the fallopian tube also. Thanks to Wikipedia for the pneumoperitoneum. Incidentally, I would like you people to know the complications of peptic ulcer, which is perforation, hemorrhage, gastric outlet obstruction, malignant change, fistula, peritonitis, and shock. So this we shall use for a different purpose at a later date, and these shall be our references. Now we shall go to thought for day 6. Please see the columns. Answer, where we should go to, what are the references, and who will be the benefactors. The questions are, say, a myocardial infarction, troponin will be diagnostic, and at autopsy, triphenyl tetrazolium chloride. The references are given over here, and the benefactors are almost any student. Dissecting aneurysm, you will have to read up entirely about aneurysms, and these are the sources. Again, almost all the students will benefit from this. Acute leukemia, it can be read from one page, Robbins, Tejinder, or Davidson, and these are the students who will be the benefactors. Finally, a perforated peptic ulcer, mainly for students of surgery, Bailey and Love can be the reference. And these are the benefactors from it. Dear students, before closing, we shall go to the questions for the next session. First question is, on an outbreak of war, arms and ammunition as well as the personnel were being mobilized. A senior Air Force officer was handed an unused aircraft. As soon as the flight ascended a particular height, the officer developed dyspnea and severe body pain. The diagnosis is anxiety neurosis, emphysema, air embolism, atelectasis. Think about it, analyze, discuss, and answer. The next question is, inoxaconilin purpura is due to congenital weakness of the capillaries, mycotic infection, defect in extrinsic and intrinsic pathways, immune complex vasculitis. The next question. Pathological manifestation in the lung in a case of embolism will be prominent in a case of saddle embolus, obstruction of a small artery, obstruction of a medium-sized artery, obstruction of a large artery. So, which of this will be producing a pathological manifestation prominently? Question 28. Patients with this disease have an increased chance of developing Parkinson's disease. Niemann-Pick, Tay-Sachs, Pompes, Gaucher's. And question 29. Alpha-synuclein mechanism is implicated in all of the following except Gaucher's, Parkinson, Tay-Sachs, and dementia with Lewy bodies. So I think that brings us to the end of the questions. Please analyze and come back with the answers. We live in the world our questions create. David Cooper Ryder. To be continued on day 7.